GI pathology section of the Falcon Reviews. So the GI system composed of the GI tract, which again is the esophagus, the stomach, the small intestine, and the colon, all covered in order in this lecture. The accessory organs, such as the liver, the pancreas, and the biliary tract, are included in separate lectures. The structural and functional things are the anatomical things that go wrong in the GI tract. These include the tracheoesophageal fistulas, the esophageal webs, achalasia, hiatal hernias, and GERD. Inflammatory diseases such as esophagitis, gastritis, or colitis. Vascular diseases such as the Mallory-Weiss syndrome. Let's start off with the esophagus. So the most commonly tested things in the esophagus are the tracheoesophageal fistulas. Remember, most of these are congenital and they present in neonates because they form during the fetus. The most common type is the esophagus with a blind pouch and the fistula between the trachea and the esophagus. It's usually due to the inability of the fetus to swallow amniotic fluid, which causes esophageal webs are usually an acquired disorder, usually in women 30 to 50 years old. Upper esophageal webs are associated with iron deficiency anemia in the condition called Plummer-Vinson syndrome. Remember, Plummer-Vinson syndrome is also associated with esophageal carcinoma, squamous cell type. The morphology is protrusion of esophageal mucosa into the esophagus. The pathogenesis causes obstruction leading to dysphagia for some. Achalasia, which is a motility disorder of the lower esophageal sphincter, is idiopathic or acquired in the type of Chagas disease. Remember, Chagas disease is a disorder by T. cruzi, and usually acquired in South America. The pathogenesis of achalasia is a lack of ganglion cells within the mesenteric plexus. This causes impaired peristalsis, or achalasia, and decreased relaxation of the esophageal sphincter. These patients also have an aperistalsis of the remainder of the esophagus, or what we call ineffective peristalsis. After having a tight sphincter for so long, hiatal hernias are one of the most common hernias seen in the GI tract. It is a protrusion of the stomach through a widened esophageal hiatus in the diaphragm. It can help predispose patients to getting gastroesophageal reflux disorder as well as esophagitis, which may be severe and medically intractable and sometimes even require surgery. Remember, in the hiatal hernia, the GE junction is pulled up above the diaphragm along with a portion of the stomach. This is in gastroesophageal reflux disease is a disorder in which patients complain of heartburn or reflux disease. The risk factors for this include hiatal hernia, smoking, alcohol, caffeine, and various types of foods, including fatty foods. Esophagitis is an inflammation of the esophageal mucosa. This can be from a variety of clinical entities, including reflux esophagitis from GERD, infectious esophagitis from HSV, CMV, or Candida, which is usually seen in immunocompromised patients, a chemical esophagitis, which is usually depicted in a history of ingestion of strong acid or alkalis, such as lye. The pathogenesis is chronic inflammation of the esophagus. This could eventually lead to strictures. Here's a picture showing Barrett's esophagus. Notice the lip of red mucosa extending above the pale pink esophagus. The surrounding pale pink mucosa of the esophagus is what is normal. This redness, which extends at 12 o'clock on the left image, is what we term Barrett's esophagus. Notice on the right the pathologic image. Next we'll talk about Mallory-Weiss syndrome. Remember, the classic history for Mallory-Weiss syndrome is a patient who has severe retching followed by bleeding or hematemesis. Most often we see these in alcoholic patients who follow binge drinking and then vomit, and then finally vomit blood. The morphology is a longitudinal tear in the esophageal mucosa, most notably in near the GE junction. This rarely leads to a pathologic condition called Boerhaave syndrome, which is a through and through tear. Remember, the difference between a Mallory-Weiss tear and a Boerhaave syndrome is the degree of the tear. If it's only limited to... Next we'll talk about esophageal varices. Remember, esophageal varices form from portal hypertension, which is most commonly seen in patients with liver disease, again, cirrhosis. Increased pressure in the esophageal venous system causes dilation of the submucosal veins in the lower third of the esophagus, which are then prone to rupture. This usually happens at a portal pressure of approximately 12 millimeters mercury. Remember, patients are usually asymptomatic. Next, we'll talk about neoplasms of the esophagus. Again, there's only two cancers of the esophagus: squamous cell carcinoma of the esophagus and adenocarcinoma of the esophagus. Squamous cell carcinoma of the esophagus is the most common in the entire world. Males and greater than 50 are what's usually seen on the boards. Adenocarcinoma, however, is the most common cancer in the United States. This is the result of the fact that reflux disease is very common in the United States, which results in Barrett's esophagus and then adenocarcinoma. So note that squamous cell carcinoma is the most common cancer of the esophagus worldwide, but adenocarcinoma happens to be the most common in the United States. Risk factors for squamous cell carcinoma include smoking, alcohol, achalasia, and Plummer-Vinson syndrome. Adenocarcinoma forms from Barrett's esophagus. The location of squamous cell carcinoma is anywhere throughout the entire esophagus. Here are a couple of pictures of what esophageal cancer looks like. On the left, you see a pathologic specimen showing the irregularity of the lower third of the esophagus. On the right, you see little islands of squamous mucosa which extend beyond the mucosal layer. Here's a picture of adenocarcinoma of the esophagus. Notice again here that this is seen at the lower third of the esophagus near the GE junction on the left. On the right, notice that there are sheets of adenomatous cells present throughout the esophagus. Now with the step 1 simulator question. A 55-year-old male has acute massive hematemesis. He's known to be hepatitis B surface antigen positive. The etiology of the hematemesis is most likely A. Adenocarcinoma, B. Barrett's esophagus, C. Mallory-Weiss tear, D. Reflux esophagitis, or E. Varices. Remember, this patient has gastric disease, structural and functional, including pyloric stenosis, congenital diaphragmatic hernia, or hypertrophic gastropathy, inflammatory diseases such as acute gastritis or chronic gastritis, and or pyloric stenosis. Again, the etiology is usually the hypertrophy of the pylorus. It's usually seen in patients between the weeks of 2 weeks and 2 months of life. It's marked by marked hypertrophy of the pyloric sphincter and results in a gastric outlet obstruction. The pathology is usually males greater than females, most common in the firstborn children, and it causes projectile vomiting after feeding. These patients also sometimes congenital diaphragmatic hernia usually presents at birth. The pathogenesis is the structural defect in the diaphragm resulting in protrusion of abdominal contents into the thoracic cavity. That is, they don't have a diaphragm that closes completely, and so anything in the abdomen protrudes and herniates up into the... Here's a picture showing hypertrophic gastropathy. Notice on the specimen on the right, the gastric folds are markedly thicker than usual. In the middle, you can see some thin folds, which hypertrophic gastropathy can be the result of any of the two following conditions: Menetriera's disease, which is a hypertrophy of the mucus cells replacing the glands. This results in decreased acid production, leading to protein-losing enteropathy and an increased risk of gastric cancer. ZE syndrome is a gastrin-producing syndrome of pancreatic adenoma. This results of hypertrophy of the gastric glands. Remember, the gastric glands are under... Next we'll talk about acute erosive hemorrhagic gastritis. Usually, patients have a history of chronic NSAID use or aspirin use or alcohol. They also have risk factors for ischemia, including smoking or other stresses such as burns, trauma, or surgery. The pathogenesis is the breakdown of the mucosal barrier, which, remember, is under the influence of prostaglandins. Any of the substances listed above can inhibit prostaglandins. Here's a picture of inflammation and erosion in the stomach. Notice that it's a small, round, superficial ulcer. If associated in a patient with severe burns, we call these Curling's ulcers. If in a patient with a head injury, we term this Cushing's ulcers. Chronic gastritis is an entirely different condition. Remember, chronic gastritis rarely causes pain. Chronic gastritis is a pathologic diagnosis. That is, it is a histologic diagnosis. Patients do not complain of chronic gastritis. This is found on histology only. The etiology of type A is antiparietal cell antibodies. Usually it's located in the fundus of the body, and it causes atrophy or loss of the parietal cells. Remember, the parietal cells are the cells in the body which produce acid and intrinsic factor, and are essential in absorption of B12. These patients, because they lack acid, are in a high gastrin-producing state. As with any patient in a high gastrin-producing state, they are at risk for gastric adenocarcinoma. In type B, this is associated with H. pylori. Remember, H. pylori normally infects the antrum as well as the pyloric area. With the infection of the antrum and the pyloric area, you have destruction of the antral mucosa. Peptic ulcer disease are ulcers of the stomach or the duodenum. The etiology is usually the result of a decreased mucosal barrier due to H. pylori or NSAIDs or steroids. Remember, NSAIDs and steroids inhibit prostaglandin production, which is essential for the mucosal barrier. Increased acid production. Here's a picture of a peptic ulcer disease. Notice the endoscopic image on the right showing the sharp, punctated ulcer. The cartoon image also shows how the mucosal barrier is broken down. Usually these ulcers are small, round, and oval, and sharply demarcated. We call these punched out. The margins are usually... There are two types of ulcers. Ulcers which form in the gastric mucosa, and ulcers which form in the duodenal mucosa. Acids which form in the duodenal mucosa are usually associated with a high acid-producing state. 25% of cases of ulcers occur in the stomach, whereas the remainder occur in the duodenum. Remember that 90 to 95% of cases of duodenal ulcers have an association with H. pylori. Thus, whenever you see a duodenal ulcer, you should always check and treat for H. pylori disease. In patients with gastric ulcers, you should still check for H. pylori and treat if positive. Because remember, H. pylori is a risk factor for ulcer disease as well as for gastric maltoma and gastric adenocarcinoma. Gastric ulcers are typically located on the lesser curvature of the antrum, whereas in the duodenum, they're located in the anterior portion of the first part of the duodenum. Remember, ulcers in the duodenum can erode into the gastroduodenal artery, resulting in life-threatening hemorrhage. The clinical characteristics that differentiate gastric from duodenal ulcers is that gastric ulcers typically get worse right after eating. Remember, as soon as you eat food, here's a cartoon image showing stomach ulcers and duodenal ulcers. Notice. Next, we'll talk about gastric adenocarcinoma. Remember, any state in which patients have a high gastrin level are at risk for gastric adenocarcinoma. The boards love to talk about Asians having gastric adenocarcinoma. Remember, there's a very high incidence of gastric adenocarcinoma in the East Asian countries. Chronic gastritis, especially with H. pylori, is also a major risk factor for adenocarcinoma. Remember, these patients have a low hydrochloric. Intestinal-type cells develop from intestinal metaplasia in the stomach, which then eventually turn into gastric adenocarcinoma. On the boards, they may describe a Virchow's node, which is the left supraclavicular node, adenopathy. If gastric adenocarcinoma metastasizes to the ovaries, we call these tumors Kuchenberg tumors. Remember, adenocarcinoma of the stomach is usually of the intestinal type, moderately differentiated gland-forming adenocarcinoma. It invades towards the mucosa into the serosa. Remember, signet rings are the pathognomonic finding of gastric adenocarcinoma. If you have the form which is a diffuse infiltrating type, here's a picture of what the signet cell looks like. Notice these cells with the nucleus. Most patients are asymptomatic until very late in the disease course. The board telltale sign seen on the board exams is early satiety. If you hear of a patient who has early satiety, the first thing you should think about on the boards is gastric adenocarcinoma. Patients may also present with occult bleeding or even iron deficiency anemia for long-term GI blood loss. Next we'll talk about maltomas. Remember, maltomas often are seen with patients who are infected with H. pylori. This is a B-cell type of lymphoma and develops from mucosa-associated lymphoid tissue. That's how they get the name maltoma. Stomach is the most common site of extranodal B-cell lymphomas. It's a low-grade malignancy and often responds to antibacterial therapy. Step 1 simulator question. A 28-year-old medicine resident is bothered by severe indigestion relieved by antacids or meals. Physical exam is unremarkable. Upper endoscopy shows a pyloric ulcer. A biopsy of the ulcer would most likely show A. Linitis plastica, B. B-cell lymphoma, C. Chronic inflammation and intestinal metaplasia, D. Helicobacter infection, or E. Candida albicans infection. In the patient with with ulcer disease, especially the pyloric ulcer, one should always think about H. pylori infection. However, a biopsy of the ulcer is likely to show acute inflammation, making the answer choice C incorrect. Thus, H. pylori infection is most likely to be seen in this patient.